It has grown over the years to become one of the biggest platforms to discuss emerging issues in the area of biosecurity, global security, and One Health in Africa. Today, we'll be focusing on a very, very important issue, which is monkeypox. And I want to say a big thank you to our participants and our panelists for joining us on this edition of GET webinar series. Thank you very much to our panelists for agreeing to share their wealth of experience with our participants. And a big thank you to our participants for joining us again today. Like I used to say, you are the reason why we organize this every month. I can see our participants online. I have participants from Brazil, from South Africa, from Liberia, from different parts of the world. Say a very big thank you to you for joining us again today. So we'll go straight to the activity of today, but before we start, for the benefit of those joining us for the first time, please permit me to talk about GET for 1 minute. GET is Global Emerging Pathogens Treatment Consortium. It's an organization that was set up exactly 10 years ago at the peak of the Ebola crisis that ravaged countries in West Africa. It was clear during Ebola that African countries lacked the capacity to cope with such level of biosecurity threats and health emergency, and there was a need to set up organizations that will work with both government and non-governmental organizations to build their capacity to cope with emerging health challenges, especially in Africa. And Global Emerging Pathogens Treatment Consortium, GET, was one of the organizations that was set up 10 years ago, with the goal of working with both government and non-governmental organizations to build their capacity to cope with emerging health threats on the continent. GET was set up by experts from about 25 different countries in Africa. And our headquarters is based in Lagos, Nigeria. We are legally registered in Sierra Leone and in Ghana and also in the United States of America. And in the last 10 years, we've been working with both government and non-governmental organizations to build capacity to cope with emerging biosecurity threats. And one of the platforms we'll be using in recent years is this GET monthly webinar series, where we'll discuss emerging important issues in the area of One Health and biosecurity. And today, like I said, we'll be focusing on monkeypox. Monkeypox, you agree with me, is becoming one of the big issues on our continent. In fact, last month in August, WHO declared monkeypox a FEC, that's public health emergency of international concern. That's because in recent years, we've seen increase in frequency, intensity, and spread of monkeypox in different countries in the world. Monkeypox naturally was endemic to Sub-Saharan Africa, mainly Central Africa and West Africa. But in recent years, we've seen monkeypox coming up in countries that never used to have issues with monkeypox, and we've seen increase in intensity and frequency of this disease. And that is why today, Global Emerging Pathogens Treatment Consortium is focusing on monkeypox, understanding the global health threats and coordinated response to monkeypox in Africa. And we have subject matter experts that will be discussing the issues with us today. We have 4 experts on our panelists that will be discussing monkeypox with us today. Without wasting time, we'll go straight to the first panelist. But before I introduce the first panelist, let me just lay the rules for the webinar today. In the webinar today, each of our panelists will be speaking for about 20 minutes. And after their presentation, we're going to give opportunity to them to respond to questions from our participants. For our participants that have questions, you can go to the question and answer section of the Zoom platform and put in your questions. And our panelists will respond to your questions after the presentations. We will also give the opportunity to 1 or 2 panelists to contribute to the discussion for about 1 or 2 minutes. So without wasting much time, we'll go straight to our first speaker of the day. I'm going to read his bio and hand over the platform to him to speak. Our first speaker today is Professor Daniel Boch, the Professor of Tropical Medicine, London School of Hygiene and Tropical Medicine. Professor Boch is an internationally recognized leader in global health research, education, and program implementation. Trained in internal medicine, infectious diseases, tropical medicine, and public health, he specializes in the research and control of emerging viruses with over 25 years experience in sub-Saharan Africa, Latin America, Asia, combating viruses such as Ebola, Lassa fever, antivirus, SARS coronavirus. He has worked and held leadership positions in a wide array of institutions, setting big and small, including academic, government, military, international, and non-governmental organizations, and professional societies. Most recently, he served as the senior advisor for global health security at FIND in Geneva, Switzerland, leading efforts on pandemic preparedness, response, surveillance, humanitarian emergencies, and antimicrobial resistance. Previously, he was a founding director of the United Kingdom Public Health Rapid Support Team from 2017 to 2021. And he held key positions at the World Health Organization, US Naval Medical Research Unit, Tulane School of Public Health and Tropical Medicine in US, and US Center for Disease Control and Prevention. And as a president of the American Society of Tropical Medicine and Hygiene. Professor Borch places a strong emphasis on partnership and capacity development and has a keen interest in the role of the scientist in promoting health and human rights, striving to ensure that biomedical advances translate to better health for those most in need. He's fluent in English, French, and Spanish. Professor Bosch, we are happy to have you on our platform today. I'll hand over the platform to you now. Thank you.
Great, thanks so much for that kind introduction and the opportunity to speak with you this afternoon for me. Hello, bonjour, buenos dias. Really looks like there's a good international crowd, so looking forward to spending a little time with you. And my goal, I'll put on my slides here. Just bear with me as we get this set up. Think you should be able to see my slides now?
Yes, you can share your presentation.
Yeah. Can you see it?
Not yet.
Not yet. Okay, I see it here. Let me try again then. Still no?
No, it's not yet on.
Okay, try again. Then I'm not sure why that's. How about now? Can you see it now?
No, not yet.
I don't know what's. Okay, well. Bear with me. It's funny because just beforehand the setup, we were able to do this no problem. But,
yes, we
you see it now?
Yeah, we can see it now.
You can see it now.
Yes, we can.
Okay, that's interesting. I can't see it now. But if you can.
So you can just put it in slide mode. Fantastic.
Yeah. You're seeing it now?
Yes, clearly.
Okay. Apologies for the delay. But nevertheless, what I'd like to do is just kind of give you the background and setting up for the other speakers of the day and kind of how we got to this particular place with Mpox and a little bit of historical background that we're right now. And So, of course, quite recently, Mpox has become all the rage and a big concern, and legitimately so. You've seen these sorts of headlines that have come out. And this is not, of course, a new virus, but there are some new things about this virus and new variants of this virus that are particularly concerning now and illustrative, I think, of really how most pathogens that threaten us in the world are not necessarily new pathogens, but ones that we've known about that occupy new niches and do some new things that concern us. And so, where are we learning about that? I won't spend a lot of time with the basics, assuming that most people online are familiar with Mpox. And I will share the slides with everyone so they can go back and review them. But just very briefly, of course, this is a virus, but the virus actually is still called monkeypox virus, but the disease has been changed to Mpox. Monkeypox was a misnomer, actually. The first isolation of the virus was from a monkey, but that was really, monkeys are incidental hosts as humans may be and don't play any role in maintaining this virus. And what we've known historically about this, of monkey or Mpox viruses, are endemic in different parts of Africa. We've historically recognized two different clades of this virus. Clade 1 in Central Africa that is associated historically at least with a higher case fatality ratio up to 10%, and then clade 2 in West Africa that is associated with a lower case fatality ratio of up to 3%. And we're not really quite sure exactly how humans get these viruses. The specific reservoir and natural history of this has not been elucidated, but we know that viruses have been isolated from a few different small mammals that we find in the forest, like forest squirrels, Gambia pouch rats, and a few other things. So this sets the stage for Mpox transmission. As I mentioned, we think that people get this from bites or scratches from infected animals, could be from hunting and then food preparation of the caught animal. But once it gets into humans, we're a little bit more familiar and more knowledgeable about how the virus is spread. And it is spread by close physical contact. That can be sexual or non-sexual with a symptomatic person. As far as we can tell, the virus does not spread from people who are asymptomatic or do not yet develop signs and symptoms of the disease, but really requires relatively close contact. So from contact with cutaneous and host lesions, the body fluids from those lesions, so the serous fluid that is there originally that then can develop into pus or blood from lesions. And then there's also virus that shed ulcers that can occur in the mouth, and so contact with saliva. There's also, this is a relatively stable virus in contrast to many of the emerging viruses, for example, relative to Ebola, COVID, or things like that. And so fomite transmission is a concern. So contact with contaminated bedclothes or bed linens or kitchen utensils can also transmit this virus. And then vertical transmission during pregnancy. And so you can tell then, seeing that the persons at elevated risk would logically be household members or other family caregivers and sexual partners of people who are infected with the virus, or health workers who are taking care of people without the adequate personal protection. What we're looking at right now with Mpox is really, there are a couple different simultaneous epidemics that are going on with the distinct clades and then a couple subclades with various modes of transmission and varied risk. So when we talk about Mpox, we really can't look at it as just one global thing. Even in Africa, it's not one particular disease or one particular modality. We have to break it down a little bit. And so the classic transmission pattern of clade 1 Mpox and clade 2 Mpox was people would get this in relatively rural areas, having had contact, probably most time recognized contact with some of the body fluids of these infected reservoirs in small mammals. They could have contact with a intermediate host like the monkey or an ape that they might have killed for hunting and for consumption, and then bring it back once they're infected, develop disease, and then give it to caregivers in the home and potentially in healthcare centers. And this was kind of the classic transmission that we understood really mimics smallpox. And then, but we've had something quite recently, and in 2022, you may recall, we had the first designation from WHO as a public health emergency of international concern when it broke out of the cycle and got really into a more global cycle, which was fueled not completely, but by to a considerable degree by close physical contact and sexual transmission. And so we have a couple of different things going on here in different ways. This will have implications, of course, on how we manage to control Mpox in different areas of the world. And part of this, these new transmission cycles have been fueled by subclades that have developed that seem to be more adapted to human transmission. So we call those clades 1B and 2B, and those have circulated to different places within Africa and some of them different places around the world. Especially 2B was the cause of the large outbreak that we saw, or global outbreak, in 2002. So here's the current situation, and as you can see from the map there, it's quite mixed. And so clade 1A and 1B are still relatively, well, I don't want to say circumscribed, because that's obviously a very large area of Africa that where you see these, but nevertheless found within areas of Central Africa, with a few different, with some a case to Sweden and a case to Thailand were brought there by travelers, and then clades 2 also primarily clade 2A in Africa, and then clades 2B with considerable transmission around the world. That has been stemmed in many, but not all areas of the world, but we're still seeing Mpox cases in high-income countries as well. But our focus really, I would say, after the designation of a public health emergency of international concern in 2022, there was a fairly good response, in my opinion, in many high-income countries, but still a neglect, really, of the response in low-income countries, and especially in Central Africa. And we're all paying the consequences of that relative neglect now, where we see increasing transmission in Africa. And so the current situation in Africa, you can see on the left, at least my left, is the clade distribution. I know it's probably difficult to see the relatively small font there, but as you saw from the previous slide as well, so we have different clades that are circulating and subclades that are circulating, especially if you look on the bottom of the table, as of September 1st, we had 15 countries reporting 3,900 confirmed cases. There are many, probably many more cases than that if we add the suspected cases. And of course, the diagnostics, we'll get into that a little bit later, are not really in place. With 32 deaths reported, but again, the surveillance for this is not great. But so a lot of action, if you will, in Central Africa, in Democratic Republic of the Congo, relatively large numbers in Burundi. You can see what I put at the bottom of this figure is not all the cases in Africa, but just kind of the countries that are reporting the most cases. And then you can see the different types of transmission that are occurring. So we have, as I mentioned in a previous slide, we have simultaneous outbreaks that are happening with transmission from, if you will, the classic way of people getting this from contact with excreta of small mammals, and then a few rounds of transmission potentially to household members or to caretakers, and then these newer subclades that have been spread, fueled not exclusively, but largely by sexual contact. And what I should say that sexual contact, we shouldn't think of this sexual contact in the same way as HIV, for example, because what we're really talking about is intimate contact. It doesn't necessarily require intercourse, and because people could not have intercourse, for example, people could use condoms, but if they had lesions in other areas of the body, would still transmit. So it's not really kind of sexual transmission the way we think of sexual transmission with some other classic STIs. And so if we look back, how did we get to this particular situation? Looking at clade 1, first of all. So once we stopped vaccinating against smallpox, we started to see, and WHO and others did some some interesting studies and evaluation of surveillance data in the 1980s and 90s and 2020 as we went on. And younger people were being born who had never received smallpox vaccination, which from all evidence does protect against Mpox. We were starting to see an increase in cases. And so if you look at the table there to the right, you'll see that these numbers start to go up. It's a little bit confusing because the intensity of surveillance and the intensity of diagnostics that have confirmed cases is quite heterogeneous around the world and in different countries. And so we can't necessarily look at confirmed cases as the indication of how much is going on, because sometimes people were really making an effort and had the ability to confirm them, and other times they didn't. But by all measures, really, we've seen an increase in transmission in recent decades as Mpox essentially fills the ecological niche that was once filled by smallpox. Fortunately, it's still a dangerous, but not as dangerous virus as smallpox was. Smallpox, of course, having been eradicated. And then we've seen in recent years the recrudescence of clade 1A in the Democratic Republic of the Congo, and then, as I mentioned, the emergence of clade 1B in the eastern DRC and Burundi, with a few isolated cases in Kenya, Uganda, and Rwanda, and the imported cases to Sweden and Thailand that I mentioned. And all of this prompted in the last few weeks, or maybe last month or so, Africa CDC to declare this a public health emergency of continental security, and WHO a public health emergency of international concern. For clade 2, clade 2 has been increasing, almost disappeared for quite a few decades in West Africa. And then maybe 10 years or so, we saw the first case of Mpox come back. And that has been increasing, especially reported in Nigeria, clade 2A. And then, as I mentioned, this prompted as 2A morphed and got out to the subclade 2B that developed, and that turned into the cause of our global outbreak and the fake declaration a few years back, with over 100,000 cases in 121 countries reported. And the disease that's caused by these different clades and subclades is not necessarily the same. So if you see the classic pictures, and you've all seen these of Mpox in Africa that looked quite similar to smallpox, and you see this young boy here and young kids that have really quite debilitating, tough disease to deal with. Whereas in 2022, in the global outbreak, we started to see much more limited and circumscribed disease with a few lesions and a few areas of the body, and lower case fatality rates than we had previously seen. And so, for reasons that are not completely clear, some subclades seem to have different manifestations, perhaps related to ways that they spread. The current WHO Mpox risk assessment is high for Eastern DRC and neighboring areas of Eastern DRC, as well as other known endemic areas in the Democratic Republic of the Congo, moderate for Nigeria and other endemic areas of West Central and East Africa, and then low for the rest of the world, but can be elevated to moderate or high for certain at-risk groups. Just a few words looking at the mortality. You'll see a lot of headlines about the different strains or clades and subclades of how dangerous they are, and saying one is more virulent or more fatal than another. In my opinion, I think we're still looking at quite a difficult situation to judge that, because the surveillance is so heterogeneous around different areas of Africa and the world, really. And so trying to figure out really what's going on when some cases are detected and others are not. And if you think about any disease, really, especially when it's first started to be noticed, it's the most severe cases that are detected, right? Because those are the people that have clear manifestations that allow them to be diagnosed, and that are sick enough to seek out healthcare and get counted, if you will, in surveillance systems, whereas the milder cases may not be seen because they don't seek such care. But if you look at some of the numbers from the WHO stats from 2024, a 3.7 case fatality rate, very interesting. And I think some of the things that are there in red is where we can really do think that these are true trends. And that is that this is a more dangerous disease for young children. So case fatality 6.7% in 0 to 11 months, and 12 to 59 months with 5.7%. And then the other group for whom this is a potentially especially severe disease is people who are not necessarily HIV infected, but HIV infected and immunosuppressed. And so HIV, most of the data don't show HIV infection alone to be the factor, but HIV infection that is not controlled. So someone who's taking antiretroviral therapy and is stable does not appear to have increased risk of severe disease, but someone who is either not taking those medicines or those medicines are unavailable for them or in end stages and severely impressed from HIV or other things, there seems to be a higher case fatality. Interestingly, the clade 2B global outbreak from 2022 had a very low case fatality ratio, less than 0.1%, and most of the deaths in that group were from people who were immunocompromised. In terms of some specifics of how people get infected with this virus, this is a very interesting study from Yang and colleagues that was published in Nature Communications in 2024, looking at different skin types and lesions in areas of the body where they could isolate virus or find viral DNA. And you can see there, hopefully, if the print's not too small, that readily isolated from the rectum in people who had lesions in that area of the body, skin lesions from the saliva and the oral pharynx. And so you can get, this is consistent with what we've thought. You can get the idea of how this would be passed on in terms of close physical contact, sometimes sexual contact, but other intimate contact as well. But also from fomites, and recognize that this as a more stable virus probably sticks around in the environment longer than many of the other viruses, emerging viruses that we're used to thinking about. And so in this study, Yang looked at basically where they could find virus in different fomites in different places where people who had Mpox were inhabiting at home or in care centers, were able to find at least viral DNA in quite a few different fomites in terms of the floor and doorknobs and things like that. And so if we think, what does this translate to and how this is transmitted between people and how we would prevent transmission, Kuhn and investigators a few months back did a systematic review of all the literature to try to sort out the infection prevention control measures that would reduce transmission of Mpox. And in that systematic review, they came to the conclusions of transmission of monkeypox virus occurs through direct physical contact. They thought that impact of airborne and droplet prevention measures would be minimal in terms of preventing spread. And the key thing was avoiding physical contact with others. That included covering Mpox lesions and wearing a mask that probably reduce transmission. And there may be an additional but minimal reduction in transmission from physically isolating patients with mild disease at home. And again, it's probably not so much the physical isolation. There's no evidence that we can find that this is really airborne or aerosolized, but the isolations of people with not direct contact with the lesions or other means that have virus. And so just wrapping up here with a last few slides and thinking about where do we go next, and the other speakers will get into much more detail about this. Thanks to them, we look forward to hearing them. But the strategies and key components of Mpox outbreak response, in my view, first of all, the funding and resources. There's no doubt that this does take funding and resources. It's a bigger question of whether the right way to fund and resource these sorts of outbreaks is really what we do in a very piecemeal way. And saying, okay, well, first it's Ebola, it's COVID, and then it's Mpox. And really, there's a bigger question of funding resources for global health in general, for WHO, other organizations, and CDC that struggle to have the resources to deal with this, not because they don't have the expertise, but because they don't have the resources to deploy the expertise that is needed. Certainly, for this or any outbreak, education and behavioral modification, engaging the community is really the most important thing. And if we look, despite, I'll get to the discussion about vaccines in a minute, but despite all the conversation that's ongoing about vaccines and legitimate conversation about access to vaccines and vaccines for Mpox exist, but have not routinely made their way to sub-Saharan some places where they're most needed. So that's, I think, a legitimate concern in my view, but it's also true that I think in the short term, at least, that vaccination will be key to control, and vaccination has not been key to control for the global outbreak of 2022. And it was much more based on education and behavioral modification to avoid close contact with people who had this disease, which I think relates to the clinical manifestations of this. But for the most part, within 2 to 3 weeks, once all the lesions have crusted and healed over, a person is no longer contagious. So avoiding that sort of close contact during those 2 to 3 weeks where individuals are infectious. And then enhancing surveillance and diagnosis, very difficult to do for quite a few reasons, but essential, of course, to do. So difficult for some of the traditional maintenance and transmission cycles that happen in very rural areas where surveillance can be quite difficult and diagnosis can be quite difficult to achieve because we don't have the resources we need, nor the diagnostics. I'll show you a little bit more about that in a minute. Vaccination, I think, an important supplemental tool at this point, but not one that is probably the center point of control. And my opinion, I'll be interested to hear what the speakers following me have to say. At any rate, we still have quite a few barriers to widespread vaccination. I'll get to those in a minute. And then treatment important because many times in outbreaks that we forget about the individual patients who are sick and needs treatment and come to think as epidemiologists do, and how do we prevent transmission? But of course, we need to make sure that treating sick people is always at the center of any outbreak response, not only because it's the ethical and right thing to do, but also because it's the strategic thing to do, because it's so important to have the community engaged for a successful response. The community won't be engaged if they don't feel like we're taking their needs seriously. And taking their needs seriously, of course, means treating them or their family members when they're sick. I've just put the links there to WHO Mpox Global Strategic Preparedness and Response Plan and CDC's plan, which of course are much more involved in this, and these come out of the one from WHO came out of our discussions after the fake designation on both 2022 and further discussion of fake designation last month. Just wanted to mention something that is important here in terms of the diagnostics. This was a performance evaluation that we were doing with my colleagues at FIND. And so we have good lab-based PCR diagnostics for at least Mpox clade 2 with good sensitivity and specificity. We have actually very little performance evaluation for diagnostics PCR for clade 1. I think most people think that they're probably the sensitivity and specificity is probably still good, but nonetheless, we don't have a lot of data. Point of care molecular tests, there are a few, and the ones for clade 2. And the reason that the clade 2 data are better is because most of these come from clade subclade 2b, as it was circulating around the world in high-income countries, and those studies got done. Relatively good sensitivity for clade 2, but the point of care molecular tests, as you can see, the sensitivity for Mpox clade 1 is not so good, and so sensitivity fell down. And then really where we like to see is a good sensitivity and specificity from a rapid diagnostic test, and something that we could get out of the laboratory and get into more remote healthcare centers in the hands of patients. And more often, we have limited data for both clades, although the test sensitivity seems to be low from initial analyses, and there's actually a more complete analysis of a couple rapid diagnostic tests that should come out from FIND. I think that the analysis is going on now. The studies are completed, and we should sometime soon have some data on a few of those tests. I'll just mention here that if you're interested in the different tests that are available, if you go to the Mpox test directory that's FIND maintains, you can find basically, and this is updated of all the tests that exist in the world. There's quite a few now. That does not necessarily mean that we have performance data on all these tests. And so important to remember that, but nevertheless, if you're curious about what tests are available and what tests, this is a place to go. And then important, of course, to have tests because this is what other things that can look like Mpox might be. And so varicella, of course, is one of the things that might imitate Mpox, as is molluscum contagiosum, secondary syphilis, a few other things as well. There are differences clinically in the manifestations that may help you sort these out in many cases, but not necessarily all cases. And so it is important to have laboratory confirmation, and that's something, a big gap. And then turning to just for a minute to vaccines, and others will talk about this in much more detail, but we have really three vaccines that are theoretically available to us right now: the Bavarian Nordic, or various trade names for that, Jynneos, or Imvanex, or Imvamune. But this is a vaccine that has been produced. All these vaccines were oriented towards variola, smallpox, but nevertheless, we have to either data or strong beliefs based on, I think, reasonable evidence that these vaccines are protective for Mpox as well. And so the Jynneos, the Bavarian Nordic vaccine, which is a two-dose vaccine that has been approved by the US FDA, the EMA, and by Swissmedic, as well as some other regulatory authorities, including in the Democratic Republic of the Congo now. The LC16 is a relatively newly developed from KM Biologics in Japan, live attenuated, derived from blister strain of vaccinia, as all of these are, from vaccinia in one form or another. This is a one-dose vaccine that's approved in Japan. And then the ACAM 2000, this is the classic vaccinia-based vaccine that was given for many years to prevent smallpox and things like that. That is not a product that is really getting a lot of use now due to concerns of secondary infections and things that might come along with that. But our challenge with sorry, before I get to that, antiviral treatment, there's a drug, tecovirimat. Unfortunately, this drug, despite being approved for 2018 for smallpox, and hopefully it's going to be efficacious for Mpox. A recent clinical trial, the PALM trial in the DRC, did not show the drug to have effect compared with placebo. There's still ongoing analysis for possible impact on severe disease for people who are treated quite early. And there's various other trials of tecovirimat that are ongoing, looking at people infected with clade 2B, a trial in various countries, the STOMP trial in the USA, but it doesn't look particularly promising right now for Mpox, and it's not widely available. I'm coming back to vaccination for just a minute. Some of the challenges we have in discussing the population risk, and so we know some of the people who are at risk, but when you get especially when people at risk for sexual transmission and men who have sex with men, has been a big risk group there. But if we look at how we're going to identify those people, we have numerous challenges. First of all, especially when we're talking about Africa, that MSM in many cases is illegal and punished by pretty considerably severe punishments. So it's not necessarily a population that is going to be self-identifying in many countries in Africa. And then if we talk about the traditional modes of transmission, clade 1 coming from small animals, trying to figure out who is at risk for that is not easy, and we don't have a vaccine to cover all the people who might live in those rural areas. There are regulatory barriers that this is true for Mpox vaccination, but for really many other compounds, trying to have a much more global and seamless response to these diseases. The infrastructure for vaccine delivery, including trained health workers, cold chain, of course, we often say, well, it's just if we can get a vaccine to a place, think that it ends there. But of course, it doesn't. We all know the challenges, even EPI vaccines and getting people. And then when you add that on to, it takes another burden basically for the people who are already working on to get those vaccines and people. And so challenges. And then supply and equity. If we look, Africa CDC recently estimated that about 10 million doses are needed. Japan has donated 3 million doses of the LC16. The US and various European countries have donated approximately another 1 million. So we're still considerably short of the target really to make vaccination really something that can be widely offered right now. So I think there's still a lot of challenges. I will end with two last slides. One, to thank these people, Federica Cambio, Debbie Emperador, and Emmanuel Gogo, who have really helped to put together some slides and to work this through. And so really part of the co-presenters in a way. And then I always end with this shameless plug for the American Society of Tropical Medicine and Hygiene. I've been privileged to be the president of that society for a few years and the scientific program chair as well. And we have our annual meeting. Actually, those dates have been changed now. It's in November, but and I know that it's not realistic for everyone to be able to come to the United States and New Orleans to join us. I hope you will be able to in the future. There are applications, at least for travel or stuff. Some people come there. And then there's not all the content, but some of the content is available online as well, including the Mpox symposium I'll be chairing. So I look forward to hopefully seeing you in person or online there. And I will stop there and happy to answer questions.
Yeah, thank you very much, Professor Bott, for that very, very detailed presentation. I would say you've given the A to Z of Mpox. You spoke about almost every aspect of Mpox, from transmission, mode of transmission to the various strains to the trend of emergency from 1970 to 2025 to risk assessment to the mortality rate of the different strains of Mpox from clade 1 to clade 2, clade 1B, clade 1A, and clade 1B. You spoke about the infectivity, talked about transmission, the mode of transmission. You talked about Mpox outbreak response, you talked about the funding, education, community engagement, the need for enhanced surveillance and diagnosis, vaccination, treatment. You talked about the vaccine itself, vaccination and the challenges that with Mpox vaccination. You talked about the sensitivity of diagnostic. Like I said, it's like you talked about almost everything that has to do with Mpox from A to Z. That was a very, very detailed presentation and very informative. And I'm sure most of our participants will still be trying to digest the wealth of information, the amount of information you've provided in such a very short period of time. So thank you very much. A lot of research has gone into this, and I'm sure I've learned so much from your presentation, and I'm sure our participants too have learned so much. So to our participants, like I said, when we start and go to the question and answer section of the platform, of the Zoom platform, and ask your questions. And I also want to inform our participants that you can watch this presentation again on the Get YouTube channel. Get Africa is our YouTube channel. And we have over 150 videos on our YouTube channel. And all our webinar series in the last 4 years is on YouTube. I'm sure there are very few platforms on the continent that have such level of information. You can go there, you can watch any of our presentations again. Go there, like our presentation, share the ones you like, and learn. There's so much information, so much you can learn from our YouTube channel and our other social media platforms. So this presentation will be on our YouTube channel from today. And I also hope we can share the slides with you if our participants, if they give us a go ahead. So thank you very much, Professor Bott, for that very, very detailed presentation. You gave it all from A to Z of monkeypox, and there's virtually no aspect of monkeypox or of Mpox that you did not talk about, from transmission to the various strains, the new strains, the challenges, vaccination, treatment, all the aspects were thoroughly dealt with. Well, I appreciate that presentation. And without wasting much time, we'll go to the next presenter. The next presenter is Dr. Sylvie Brand. Dr. Sylvie Brand is the Director of Global Preparedness Monitoring Board Secretariat of the World Health Organization, WHO, in Geneva, Switzerland. Dr. Brand has been at the forefront of managing acute infectious risk to global health for more than 20 years, ensuring the development of global mechanisms, sustainable frameworks to facilitate multi-sectoral and multi-partners coordination for epidemics and pandemics. Since 2001, she has been actively involved in the detection, preparedness, and response to global threats, leading the scientific and strategic components of the WHO response. That's to avian and pandemic influenza, Ebola, Zika, plague, yellow fever, cholera, and MERS. Before joining WHO, Dr. Brand worked as Public Health Project Director for different global health agencies in various geographic locations. We're very happy to have you today, Dr. Brand. Thank you very much for joining us again, and please, you have the floor. Thank you.
Can you hear me? Hello?
Yes, I can hear you.
Okay.
We can.
Okay, because I have a strange message on my screen, but yeah. Okay, thank you. Good afternoon, good morning, good evening, depending where you live, and thank you very much for inviting me to participate in this webinar. It's a great honor for me to have the opportunity to interact with you all. My bio was a bit out of date because though the title is correct, but I've been directing the Department of Epidemic and Pandemic Preparedness and Prevention at WHO for the past at least a decade. I've recently moved to the GPMB Secretariat, but I was at the forefront of COVID response and Mpox response in 2022. So these are topics that I have managed for many years. So that's why I'm so happy to be able to contribute to this discussion. Indeed, Danielle has said almost everything about the subject, but I will try to provide you with a perspective on equity and how equity matters for this kind of response. So it's a slightly different approach, and I'm very happy that Dan has provided all the content regarding the disease and activities that are currently ongoing on the response, so that I can maybe concentrate on other aspects of this crisis. So I was not aware that we could have slides, but I've prepared a very short presentation with slides, so I will try to share it. Can you see it?
Yes, we can see your slide.
Okay, great.
Let's put it in slide mode.
Yes, now it's okay. Okay.
Fantastic.
So I just wanted to look a little bit at the recent past, but also at global architecture to respond to pandemics and epidemics. And on the top of the slide, you see the recent outbreaks we have had in the world, starting maybe in 2003 for this century at least, with SARS. Then we had H5N1, avian flu. Then we had the flu pandemic in 2009 with H1N1. Then we had significant outbreaks of cholera in Haiti, which was really new for this part of the world. We had also MERS emergence in 2012, H7N9 in 2013, which was fortunately only in China and has now disappeared with a very strong strategy to control this new type of avian flu. We had Zika also in Brazil. I hope you remember this crisis, which was very hard for many children in this region. Ebola, of course, in West Africa, yellow fever in Central Africa and in Brazil in 2016. We had also, of course, plague in Madagascar 2017 and COVID-19. etc. So many outbreaks, and Mpox has been recently coming back, although it was endemic, but really at low level. But we have had this spread in all continents in 2022. So. But what is interesting is that in the bottom of the slide, you can see that every time we have had such a global event, or at least multi-country epidemics, we have had also a mobilization of the international community, WHO member states, to develop mechanism or framework that allow us to respond collectively and in a coordinated manner. So, of course, I think what is important is to see the point in 2005 with the International Health Regulation, because this framework has been updated in 2005, and it was just after the SARS, although the negotiation has started in the previous century, but it's the SARS outbreak accelerated the negotiation for the revised IHR in 2005. And this is a framework that allows us at global level to coordinate a global response. And so this IHR, and if you look at the other angle of the slides, on the right, you see that it is being reviewed as well, and the last amendments have been adopted at the WHO in May 2024, but this new version is not yet in place, in force, because it requires at least endorsement in each country, in each member state of WHO. So that's why it will take probably 1 year to be put into place. In addition to the IHR, I think you can see other important frameworks. For instance, the R&D blueprint that was developed after Ebola outbreak to call for more research on those pathogens that are most of the time at a low level of transmission and not really a global issue, but may become something that can threaten an entire region or even the world. And so that's why now there are research programs in different parts of the world on viruses such as Ebola and so on. So there are also other important structure, like for example the Gavi, which was created in 2000, and really Gavi was initially to promote the expanded program on immunization, but gradually Gavi has been taken on more roles and responsibilities in the area of vaccines for emergencies. We had also the creation of GOAN, which is an international network of experts to support outbreak control. And I would like to mention also the ACT Accelerator, which was a group or consortium of different agencies, and FIND mentioned by Dan was part of it, but there was also the Gavi, the Global Fund, UNICEF, other UN agencies, etc. So a number of agencies came together to help to accelerate the research for tools against COVID-19, but also to accelerate the development and the delivery of those tools to population in need. So Act A was focusing on COVID-19, but gradually as well, it still exists, and they see if maybe their mandate can be expanded to other diseases, so that this group can also be effective for other types of outbreaks. And finally, the last but not least, of course, is the INB, which is a intergovernmental negotiating body, and this body is in charge of negotiating the pandemic treaty. They are currently meeting in Geneva, and the negotiations are ongoing to see if we will have a pandemic treaty for the next pandemic. So this is just to set the scene, and you see the international architecture is quite crowded and becomes more and more crowded as we have more outbreaks, because there are different needs that are emerging. And so, and this global health architecture is obviously very dynamic and moving, and trying to adapt also to the high number of crises that we have currently in the world. So just a very quick slide on the role of WHO, which is not only to to host the international health regulation, but also to be the secretariat of this framework and to implement this framework. But also WHO has a role in strategic, technical, and scientific leadership. And regarding monkeypox, there have been a global strategic framework for enhancing the control and achieving elimination of human-to-human transmission of monkeypox that has been published in 2023 after the outbreak of 2022, and a number of guidelines and support to countries to try to be better prepared for those threats. So this is the slide on the epi curve on the 2022 and up to 15 August 2023, but it's just to show that even if it's the same disease, as Dan very rightly mentioned, it's different strain, and it's very likely that the strain have different characteristics as well. But also at that time in 2022, really the world mobilized itself because the disease was really escaping its natural ecological niche, I would say, because it was really, we had a number of cases outside Africa in places where before there had never been any cases of Mpox. So there was a lot of interest in this disease at that time because of the fact that it was very new. And in 2022, really the affected regions were the Americas and also the European region. And we think that probably this transmission happened at a time where the COVID lockdowns were lifted and people were allowed again to travel, and so there was a lot of big parties everywhere in Europe, especially in summer, and in the Americas as well, where people from different countries, different regions of the world were meeting, and of course at that time it amplified the transmission significantly. But after some time, through really a good risk communication, engagement of special communities like men having sex with men, and informing them about the risk and how to prevent the transmission of the disease, we have seen a very fast decline of this disease in those regions, and it happened even before the vaccine was introduced. So I'm not saying that the vaccine is useless. I'm saying that the vaccine is a very important additional tool, but we shouldn't undermine the effectiveness of engaging with peoples and communities, so that if they know about the disease and the way to prevent it, they can do a lot about it. Also, as you see on this map, just confirm what I was saying in the previous slide, is that really the region in blue were the one most affected at that time, and so that's why there was a lot of mobilization of the world, and this mobilization decreased after some time because the outbreak was under control in those countries, and other crises came in, not only Ukraine but Gaza and other crises that shift the attention on other things. So this slide is just to say that in this reflection at global level on how can we deal better with outbreaks of the 21st century, WHO has developed a health emergency preparedness and response framework. And the interest of this framework, in my opinion, is that it shows clearly that we need at least the 5 C's to respond properly to an outbreak. So 5 C's are the collaborative surveillance, community protection, clinical care, and access to countermeasure, and emergency communication at the center. And I think it's very important to have this framework in mind, because it shows that if we want to be effective in controlling a disease, an epidemic disease, we really need to have all those bubbles together and not focus only on one bubble. It would be, for instance, just the vaccine, because the rest is also extremely important. So, but I know that everybody is talking only about vaccines. So, and the fact that there have been a public health emergency of international concern declared activated really this movement of international solidarity, which is very good. So vaccines are coming slowly to the affected country, and in particular in DRC. There are more vaccine in stocks, and they have to be moved as well. But what is I would like to highlight with this slide is that the vaccine we are currently using are both vaccines, either Bavarian Nordic vaccine or called Geneos or Imavun or Imavex is and all the other one, which is LC 16M8. All those vaccines were developed for smallpox, and so that's why some governments have them in stock. But it's not because they were anticipating an Mpox outbreak. It's just that this vaccine is made with a vaccinia virus, which is not a variola virus of smallpox, nor the Mpox virus. It's another virus, but it happens that within the orthopox virus family, there is a lot of cross-cutting immunity. And so, which is really good, because then if you get antibodies against one disease, it also protects you against another disease. Maybe not perfectly, but at least enough to give you some protection. So this is why some countries, because they were afraid of having re-emergence of smallpox, even if this disease has been eradicated in the 80s, they thought, okay, let's stockpile some vaccine against smallpox, so that if it re-emerges, we have the tools to respond. But in reality, smallpox, unfortunately, has not re-emerged. And so now we can use these vaccines for Mpox. But it gives you a sense of the complexity of dealing with emerging diseases, because for this time we are lucky in a sense, because we have a vaccine for Mpox, but the use of this vaccine is not so easy. And this is why we are talking about equity in the response. So I'm now heading the secretariat of GPMB, which is the Global Preparedness Monitoring Board. This is a group of 17 very high-level senior officials who are really looking at the preparedness of the world and providing recommendations for countries on how to deal with pandemics and epidemics. So the GPMB issued a statement on equity in May 2024. And this statement on equity really was highlighting for all the countries in the world that there is an interconnectedness between equity and health security, and emphasizing that no one is safe until everyone is safe. This has been said a lot during COVID-19, but we can forget very easily this kind of very good principles. So it's very important to highlight them again and again. And they also highlighted that equity is not only a wise political choice or an important choice for equity and social justice, but it's also instrumental in preventing epidemics and pandemics and mitigating their impacts on our economies and society. And indeed, we have seen this during COVID-19. When you have some places where the virus continues to circulate, the virus can evolve and create new outbreaks somewhere else. And so it's very important to understand those interactions between humans and viruses or dangerous pathogens, not only as local problems or even national problems, but really at a global issues that needs a collaborative response. And this response needs to have equity at the center. And this is just an illustration between equality and equity. And really here it's to show that we need to put in place mechanism, and those mechanisms can be represented here as a stool that is on which those people are standing. And when you have more needs, or you have not an easy access, you need to have more support to be able to access the tools that you need to respond to the outbreak. And we have seen previously in any other outbreak that indeed there is always a lot of inequity. And this is due to the fact that so it's due to many factors, but most of the time is the first come, first serve. But in the case of Mpox vaccine, is more that countries have them in stock. It was security stock that they were kept for a specific as a safety net in case of smallpox re-emergence, and so now they need to have a discussion at country level to see how much of those stocks they can free up to support the countries in need. The manufacturers also can produce more, and there is also a need to discuss with them and see how they can produce more vaccine at an affordable price, of course, and see how we can maximize the access to those resources. You tell me if I am too long, but I will just finish on this aspect of equity. I think equity is very important, but it's not only vaccine, it's really equity also in access to all technological innovation, be it the new rapid diagnostic test, be it new treatment, etc. And it starts with research, when we need to embed equity in the research, and then it should flow through the manufacturing and the distribution and the delivery of the vaccine or any other technological innovation. So equity is needed at each step, and I think we should, at international community, look at this equity issue really with a much broader lens than just the delivery at the end of the chain, but really making sure that each step is addressed. And the point also about health system, we know also that the best way to reduce mortality during epidemics is to have a good care of the patient, even if there is no specific treatment. During the Ebola outbreak in 2016 in West Africa, we did a study that shows that even with only supportive care, we were able to reduce the mortality from 75% to 33% just by providing people with good care. So good care is a very important aspect of reducing mortality. And here I just chose those slides because they are really out of date because it's from 2003, but it was just to compare two situations in the world, SARS outbreak in Hong Kong and cholera outbreak in Niger. And you see that the capacity for response and the capacity to treat is very different in different parts of the world, and we need to address this inequity. So the GPMB had 6 recommendations to put equity at the center of an effective Mpox response, monitor the outbreak with an equity lens, enhance equitable primary and community healthcare system response, ensure equitable access to medical countermeasures, engage communities, civil societies, and vulnerable groups in prevention, preparedness, and response, ensure financing to bridge the equity gap, and mitigate the economic and social impact of the disease spread on vulnerable groups. Because as you know, when you have Mpox and you have spots on your face and you are an informal worker, for instance, you may not be able to work during the disease, and the disease can last 2 or 3 weeks. And so for those informal workers, I mean, having this disease is terrible. So we need to put in place mechanism to make sure that those people are protected, not only their health, but also all the social and economic aspects of their lives. Do I have time to continue? I have a few slides on drivers of pandemic. I have no response for my moderator, but
please go on.
Okay, so just very quickly to tell you that I think we should really look at pandemics and epidemics with a very broad lens, not only focusing on the medical aspect of it, but also looking at all the other drivers that will amplify outbreaks. We have, as a GPMB, we are going to publish a report on those drivers, but we have classified them in 5 categories, which is called, sorry, the steep approach. I need some drink. Sorry, the steep approach, social, technological, environmental, economic, and political drivers. And we have done a sort of a heat map of risk drivers. And what is interesting in the situation in DRC and neighboring countries is really that you see that many of these drivers are, so this heat map is not for this outbreak, it's for the world. So, but you see that some drivers are existing currently in DRC and neighboring countries that will have an impact on this outbreak. And that's why it's very important to take them into account to make sure that we can not only treat patients and reduce transmission, but also address the root cause of transmission of this disease in its particular context. And for instance, the movement of people is one of the drivers. The fact that there is conflict and instability is a real drivers, because people don't have necessarily access to healthcare facilities. They won't necessarily have access to the vaccine if vaccination campaigns are implemented in certain part of the country. Those people may not be willing also to notify that they have the disease, because they are afraid of the consequences that it could have on their family or on their communities. So conflict and instability are driving really the transmission of infectious disease, and it's very important to take them into account. The fact that viruses are on the move, and this is again a global slide, but this is a situation we see also in Africa. People and animals are moving a lot. And in addition, they are concentrated sometimes in city, especially when they have we have to move from their rural community and to find some help in neighboring cities. So when people move, viruses move. And so we need to take into account this movement also to base our strategy of response. And we are also looking at other factors that are also very important. In many countries, we see that health systems are evolving. And in particular, the privatization of health services is really exposing countries to more vulnerabilities, especially inequality in access, but also less coordination between private and public sector for the delivery of care, especially during a response. And so we need to see how we can enhance this coordination, especially emergency coordination. And finally, it's also very important to have an effective governance during crisis. And maybe we were used to have an approach that is very top-down in dealing with epidemics, but it's also very important to empower communities, give them the right information at the right time, give them as many tools as possible so that they can also manage the risk at their level, because the local level is very important. And as my former boss was saying, Mike Ryan, outbreaks start in communities and end in communities. So it's very important to adapt the governance to this kind of context and have more inclusiveness, more equity, more flexibility in the way we respond, and also make sure that we always learn from the previous crisis and try to do better next time. And with this, I thank you very much. Merci beaucoup. Gracias.
Thank you very much for Dr. Brand for that very informative presentation. Merci beaucoup. Thank you. That presentation was very detailed, especially focusing on equity. Something that COVID taught us is that pandemics have no respect for borders, and they continue to move. An outbreak anywhere in the world, if not addressed as early as possible, can be an outbreak everywhere in the world within a very short period of time. So thank you for the detailed presentation, and for letting us know that equity is very important. Response to pandemics should be global, and there should be global collaboration to address any form of disease outbreak anywhere in the world. And just a recap of what you said, you started with the various outbreaks in the 21st century, and it showed clearly that in the 21st century, we've seen increase in frequency of disease outbreaks, pandemics, and epidemics, from Ebola to COVID to Lassa fever to Mpox and to other forms of emerging infectious diseases. And most of these diseases are zoonotic, from animal to humans. And talked about the framework, various frameworks, especially the IHR, International Health Regulations, and how these frameworks are very useful in responding to outbreaks anywhere in the world. Talked about the role of WHO in prevention, preparedness, and response.
Come on. We lost you. Hello.
And especially the health emergency preparedness and response framework, the need for collaboration, vaccine, and equity. Equity equals to health. Nobody is safe until everybody is safe. Equity in vaccine access, equity in access to technology and innovation, and importance, the need for us to have good health system to reduce mortality, especially during outbreaks. Talked about the GPNP6 recommendation for equity to effectively respond to Mpox. And you talked about the pandemic risk drivers, the steep approach, the social, technology, economic, environmental, and political approach to pandemic risk drivers. So thank you for the very detailed presentation. Like I said before, we have these presentations. The video will be on our YouTube channel, and always go there and watch after this presentation. Our YouTube channel is Get Africa, capital GET Africa. And I can see we have about 14 questions on our question and answer platform. On the question and answer section of the platform. I kindly request that Dr. Brian and Professor Borch can just see if they can answer some of those questions. Our time is fast spent, and we may not be able to have time for question and answer. So our panelists can just see if they can respond to some of these questions directly on the platform. And without taking much of our time, I go straight to our next presenter. Our next presenter today is Professor Oyewale Tomori. I'll read his bio and hand over the platform to him. Professor Tomori received a Doctor of Veterinary Medicine DVM degree from Ahmadu Bello University Zaria, and a doctorate degree PhD in virology from the University of Ibadan, Oyo State, Nigeria. In 1981, he was appointed a professor of virology at the University of Ibadan. The same year, he received the United States Department of Health and Human Service Public Health Service certificates for his contribution to Lassa fever research in Africa. 3 years later, as in 1984, after his appointment as a professor of virology, he was appointed the head of Department of Virology at the University of Ibadan. Professor Tomori's research interests focus on viral infection, including Ebola, yellow fever, Lassa fever, and other viral infectious diseases. He served as a regional virologist for the World Health Organization African region between 1994 and 2004, before he was appointed a pioneer vice chancellor of Redeemers University, Ogun State, Nigeria, a tenure he ended in 2011. As a regional virologist, WHO African region from 1994 to 2004, Professor Tomori was instrumental in setting up the African Regional Polio Laboratory Network, a network of 16 laboratories that provided crucial diagnostic support to the Global Polio Eradication Initiative. Professor Tomori is also one of the founding fathers of Global Emerging Pathogens Treatment Consortium, GETS. His work has been acknowledged with the Nigerian National Order of Merit, NNOM, Nigeria's highest award for academic, intellectual attainment, and national development, a testament to his respect and admiration, admiration his work has gained in Nigeria, Africa, and all over the world. Prof, please, you have the platform.
Thank you very much. Can I share my slides?
Yes, you can, please.
Okay. Okay, now I will find where the slides are. Just a second. I get it. Can you see the slide?
Not yet.
Just a second. Is there anything coming up?
Not yet. You can see your face, not the slide.
Oh boy. I thought I did the Zoom thing. Just a second. Sorry about that. I think you should, okay, share. Okay. I think I did forget to share.
Okay, yes. I think it's coming up now.
Something is coming up.
Yes. I see something.
Is it there now? You should have my slides.
Yes, I can see your slide now. Fantastic.
Okay. I just wanted to see. Okay. Thank you very much. It's such a delight to see so many people on this panel. Dan Bausch, so nice to see you again. Sylvie, it's been years since I saw you last, but you're looking very good. So you must have been having a good time in your life.
So here, Wally. Yeah.
Let me say from beginning, I'm going to come from the opposite end of all that everybody has said, because I'm an African, and because I think we're going through the issue of epidemics and control in the wrong way. We've been saying it, but nobody seems to listen to us. But we'll see what we can do. Let me just see if I can enlarge my slides. Can you see it in the big size or something? You can see some little. I really wanted to see it bigger than, okay. Yeah, you can see it now. So you remember in, I think it was June 2002, when this GETS also had this meeting about whether the kind of, just a second, I'm trying to settle down because some of my slides are not showing where I want to see. Okay, you remember, I think it was June when the epidemic first came out, and then GET also held a workshop. So should we expect another global epidemic? And that time I said, the ready and simple answer is yes. And then I will tell you why. But now I don't have to tell you why. You've seen it is happening. So today we're looking at monkeypox disease. Should we, or Mpox disease, monkeypox virus, should we expect another epidemic? Then we're looking at understanding the global health threat and the coordinated response. Let me start, because of time, just go straight away to what we must do to solve the Mpox and other diseases problem. We must accept that Mpox is our long-standing problem in Africa, that the situation is getting worse by the day. The world did not come to our aid in times past, so we better not wait any longer for the world to come to our aid. We must wake up from our slumber of dependency and realize that the world really owes us absolutely nothing. We owe ourselves what we desire. We must build on our strength and work on our weaknesses. We must put our money where our mouth is. We must understand that equity is not achieved by begging or pleading. I was listening to Sylvie talking about equity, but really, from day of generation, from the time God created all of us, I'm not sure there was equity. Because if there was equity, he created all of us equal, but he had his own anointed. So where is the equity? So let's not talk about equity. So you bring your wine to dine on the equity table. Otherwise, you will whine and you go in tears. You must get to work now, and then let not corrupt our wine. So that's picture of Africa. So I'm not going to go into details. You know we've had problems. This is the situation in the African region starting from 2002 up to now, because I'll leave that. And the African CDC came up with this slide showing that between 2022 and 2023, there was 79% increase in number of cases. And then between 2023 and 2024, yeah, it is 160% increase. So it's a continual problem. And they came up with all these figures, 14 African countries, member states, where you're having all the viruses in different cases and different situations. I think it's only Cameroon that has both. The South, the Central and West has clade 1, and then we in the West, we have clade 2. South Africa loves us so much and decided to have clade 2 and not clade 1. And again, you see, in 2024, 4 countries have reported this. This came out from WHO side yesterday, which also brings me to one important thing. We have two agencies in Africa, African Center for Disease Control and WHO Afro. You expect both of them should work together, but they are competing with each other. And that's part of our problem in Africa. Until we begin to look at the African CDC has its own strength. WHO Afro has its own strength. Both must work together and make use of those strengths rather than use our strength to fight each other. So I hope those people in African CDC and WHO are also hearing what we're saying. We are worried that this thing is moving, not just in DR Congo, it's spread to other countries, neighboring countries, Rwanda, Burundi, Uganda, Kenya, and so many others, even South Africa, although it didn't get its own from this thing. So it is becoming a risk. The fatality rate is quite high. It used to within just 10% when our surveillance was not that good, but now I think we're looking settle down between about 4 or 5%. But even if it's 0.1%, any mortality is a problem. The increase in border spread, and also the fact that the virus is mutating. Then again, the last one that we always grumble and whine about, there's no vaccine. But then there's so many other things in our hand that we can do, which we can forget about the vaccine. I'll talk about that. And every year we talk about our challenges, weakness of One Health coordination. I just mentioned African CDC will not work with the WHO. Even in our countries, we don't work with each other. The vets are not talking to though this is a monkey problem, this is an animal problem, but the medical people will want to sit down on it alone, and the vets will either too ashamed or too shy to go up and say, this is our area, let's work together. Surveillance is poor, everybody knows that, but then when you say surveillance is poor, I think these are some of the things that we're having a big problem in Africa. Surveillance shouldn't be poor. 50 years of yellow fever, 50 years of monkeypox, 50 years of that one, you are still saying your surveillance is poor. What type of thing is that? Let's move on. We talk about IPC and RCC. Oh, we don't have gloves, we don't have, who is going to buy gloves for you? You can buy cars, you can buy, your presidents can buy jets, but they can't buy gloves. You know, the laboratories are not there. When Nigeria started with COVID, we said we had only 3 laboratories. And then by the time COVID finished, we already ended up with 150 laboratories. But let me tell you, 6 months into the COVID, 50% of those laboratories were not working. Why? Because when you gave $100 or naira to come to a lab to be built, and you say 50 naira for the building, 30 for the equipment, and 20 for staff, we use 20 to build a lab and pocket the 80 naira. And then 2 weeks later, the lab is not functioning. And then we talk about medical countermeasures. Again, that's something. Just again yesterday, WHO delivers 14 tons of emergency supply of monkeypox response. It's going to take them another 20 years to even to deliver that one. Our challenges are for half a century of lies that we tell ourselves. And the challenges are the wrong names that we are called and we accept. Let me go into that. How do they call us? We say we are a resource-limited setting. That's what Africa is about. We are resource-limited. But are we really resource-limited? We are not. We are resource-squandering. We are resource-wasting. They say we are resource constrained. We're not resource constrained. We are corruption constrained. So when they give us this tag and we begin to solve our problem under the belief that we're resource limited, that's why we never find a solution to it. But if we knew we're resource squandering and resource wasting, then we stop wasting our resources, we stop squandering our resources. And then, you know, but when you say you're resource limited, you go into a depression of self-pity. Oh, poor Africa, we are so limited with this thing. That's not true. We are not limited. We are not constrained. We are the ones constraining ourselves. We are the ones squandering our money. We are the ones wasting our resources. Let me show you a good picture of what situation in Africa is. Africa's natural resources. Look at that map. You see more. Name any country in Africa. There is something on the ground which is untapped, which has not been used of. Look at that situation in terms of the situation in the world. South Africa, I mean, name the drug. Either we are first that have the largest reservoir, or we are the second, or we are the third, and then you say you are poor, and you say you are resource limited. All of this from some countries, the diamond in Botswana is enough to solve the problem of most of the African region, and yet you say you are resource limited. Who limited you? Look at the situations. Most of the commerce activities has followed. So Africa is estimated to be losing over 50 billion annually to whatever, offensive tax, corruption, tax evasion, collusion between these people and everybody, you know. And then you say we are resource limited. About 92 billion went out of Africa one of the years last year. How much of it came back? Not much in terms of aid. So look at how that 192 billion went out. The inflow that went to Africa through AIDS and all the official aid assistance they give to us, it comes to 133 billion. The one that either we are paying debt or we put it in European banks or Western banks or all those profits that those will take is more than 192. So we have a shortfall. And then you say we are limited because the money we have, we gave it out to around people. Africa has become, when you're talking of the equity table, that's my equity table. The equity table is Africa. The Africa is the food on the equity table. And other countries are eating up on Africa. And see the a la carte menu. The main course is sweet Nigerian oil, high nuclear, whatever, from Nigerian uranium, captivating Congolese citron, which they use for all the other things. And then, of course, we have desserts from different parts, the cocoa from Ghana, the Zimbabwe tobacco, and all those kind of things. And then we have a nightcap with Madagascar, Habati, and all sorts like that. 65% of AU budget is sourced through non-member state. This is the country that has one of the richest deposits of everything, most of the countries that have. In 1989, I mean, I'm talking about the African Union. 21 years later, all the 54 members, they are still depending on those things. When you call an OAU meeting, you know, 1/3 of them will go. Xi from China will call, only 54 of them will run to China. Biden will call, only 54 of them will run to China. Come to AU, your own meeting, half of them will not show. And you're telling me you are resource limited. They didn't have the resource to go over there they don't have resource to go to Addis Ababa, but they have resource to travel to China. So these are the things. The whole center of AU, even the African CDC, it was China that built it. African CDC is in Ethiopia, funded by the Chinese government. So what really do we do with our resources? Where do we go? We have untapped resources, we have unused resources, we have underutilized resources, we have resources that have no value added, we have our resources looted, we have them stolen, we have them wasted. See the kind of, when we're talking about equity, now I see what we're talking about equity. That's the car of my president. That's the vehicle of the average Nigerian with the woman with 4 children on a bicycle. And my president with only 1 person and 2 other people running after him will ride that on. And these are the kind of things. That's the kind of thing my president lives in that house. The richest worker in Africa lives in the house to your right. Our strength, I want to talk about that. We have strength, and we have strength. Africa's health workers have over 50 years of experience dealing with different kinds and diverse types of epidemics. And let me give you 1 or 2 good examples of epidemics that didn't happen through the work of the average African on the road. In 2014, Ebola came into Lagos, a city of over 21 million. Everybody thought that was the end of the world with Ebola coming to this. In 3 months, with simple surveillance, contact tracing, the Lagos state government, I mean, kudos to them. Within 3 months, we took care of Ebola with 20 cases and just about 8 deaths or something of that nature. That was, no vaccine was used. It was just simple community involvement, contact tracing, isolation of cases, and that. That was repeated in 2018 in Kenya when they had an outbreak of anthrax in a rural village. They got their own people together, got it coming together, and nipped that in the bud. It didn't become a major, an international, it didn't become a fake. In 2019, Ebola crossover from DR Congo into Uganda, and it was limited to that area, just 4 cases that they had. In 2002, DRC itself contained the 14th epidemic right within a month. All these outbreaks in all these states were brought under control without a single dose of vaccine, but through surveillance, case detection, diagnosis, case isolation, contact tracing, and awareness. These are the epidemics I'm talking about. Since 1969, Lassa fever, monkeypox 1970, Ebola since 1976, SARS-CoV during the 2019. We don't know when disease X is coming. So that's what shows you that Africa has adequate human resources with years of relevant experience, skill, and expertise in responding and controlling disease outbreaks. Africa, however, disdains and discountenances this unique resource and embraces our weakness and poverty in the area of vaccines. Our government will not put money into this, create a neighboring environment for the surveillance. All these experiences, all these talents that are found in different parts of Africa. How much money are we going to put into that compared to what we get into getting a dose of vaccine, for example? Or compared to what the epi divisions in many of the local governments, they don't have a bicycle to go out and get vacation. Yet the spare tire of the car that my president bought will buy enough vehicles for all those people to carry out investigations. African scientists say Western aid to fight epidemic is backfiring. It is. Some of you will not, a lot of us, or like people like me, I have nothing more to do. A lot of you who are looking at me, you are worried that, oh, are you going to get that $1,000 extra to travel to UK? Therefore, you won't talk when you should be talking. Yet we remain like that. Your generation, my generation, your children's generation will remain in this situation of resource limiting, resource whatever that we call ourselves. Let me just go. So just to remind us again, the control and containment of even the people that moved out of Africa into Europe and other parts, what has it done? Yes, they did a little bit of vaccination, but the success of it came out of surveillance, detection of laboratory cases, through isolation of cases, through infection prevention and control, and some targeted vaccination. The crux of that control was basically on that simple surveillance, simple isolation of cases, simple infection prevention control. That the vaccines came in just a little. Africa has a wrong notion about equity. You do not beg or cry for equity as we currently do. You fight, not physically. You fight your resources, your untapped resources, your wasting, illegally shipped out resources to negotiate for equity. To the equity table, you must bring something to the table for negotiation. If you bring your raw material, you get a raw deal. If you bring nothing, you get no deal. Simple. So what do we need to do? Self-reliance. Let's stop begging for aid and crumbs. Aid aids the aider more than the recipient. Even the Bible said that one. Let us reverse the legal transfer of resources through accountable transparency. Let us tap our untapped resources. Let us limit our waste. Let us focus on our capacity. Let us build the enabling environment to retain the capacity. Nigeria, those of you in Nigeria, you know we talk about Japan or something like that. Again, create that enabling environment for your build capacities to remain. It is not capacity building alone. It is important to have capacity retention. Help stem and reverse this brain drain. Let us collaborate at home, all of us. One health. I'm going to talk about that. Let us all work together. Whether politicians or whatever, and they are the ones most guilty. And the rest of us who should be talking are not talking. We are equally guilty. We must improve our language of conversation with these people. We must stress to them that it's a win-win situation. If there is health in your country, you need more people. You get more people to vote for you at the next election. Let us embrace One Health. I mean, I won't talk too much about that, but you all know about One Health. You see the kind of thing about One Health, right? People are connected. You leave instead of leaving the animals where they are, we go and carouse with them and get them, and we get their virus, and then we start complaining that we have epidemics all over the whole place. So preventing, controlling, and limiting the global epidemic starts not from Sylvia mentioned that about Mike Ryan. Starts not from New York, not start from London. It doesn't start from, it starts from my mother's village, with the assistance and guidance from and awareness by my local government, my state government and federal government, we can find solutions to some of the problems we have in our hand. So again, it took months to identify the disease, the 2014 to 2016, because of so many of the problems we have. These are the areas that we pushed on. We keep telling we are weak, we are that. We are not. We are not. Time for us to begin to see that it is far cheaper and most cost-effective to provide funds for reliable preventive surveillance rather than responding to an epidemic with federal consequences. And we must prioritize our surveillance rather than this. How much vaccines are we getting anyway? And when shall they come? See the graph that is showing you. The total is less than 100,000 for how many people? And some of them will not come on the 2025. What happens in between that time when you're waiting for the vaccine? Get your surveillance in place. Get your people, reduce the number of cases. If you can nip the case in the bud, then of course you won't get epidemic. A neglected disease becomes the outbreak for increased GDP. Don't think it's the GDP that we're talking about. It's our gross domestic poverty. And that's what we're getting. We are getting gross domestic poverty in Africa because we are neglecting our diseases. So with that performance this past 50 years, our children should be angry with us, and rightly so. Look at the face of those children. That's what is happening. Thank you, my friend. I'm so incensed about what is happening in Africa that I don't even have the want to say thank you very well. Thank you.
Yeah, thank you very much, Prof, for that very direct presentation. So giving the solution the way it should, and it's not academic solution, but talking reality to stakeholders and let people know that nobody gives you freedom. Freedom is not given a la carte. And like you said, you bring your wine to dine on the equity table. Nobody, there is no free lunch anyway. If it's free, somebody somewhere has paid for it. And Africa is not poor. Africa is not poor. Africa is not poor. We just need to accept our problem, build on our strengths, and work on our weakness. I hope stakeholders will understand this as soon as possible. The cycles of pandemics and epidemics are reducing. We had Ebola 10 years ago. We had COVID 5 years ago. Like you said, disease X. We don't need the Muganga to tell us that something's around the corner, and how prepared is Africa. I hope something else will not come and we'll still be going around the world begging for vaccines and begging for the basics we need to solve our problems. Nobody will solve African problem for Africa. When Africa is ready, Africa will rise up to address its own challenges. Talking about challenges facing Africa, the need for African CDC and African WHO to complement each other and work together. We can't continue to work in silos. Everybody has to bring a strength to the table and work together for us to solve emerging problems on the continent. The challenges of weakness in multi-sectoral and One Health constraints, surveillance, poor surveillance, infection prevention and control issues, what we call resource limited, but we are not really resource limited. We are just resource condrars. And you show those different graphs and different charts that shows that if it's either you're on the table or you're on the menu, and Africa has been on the menu for so long. It's high time we'll come to the table of negotiation with our strengths and stop begging for it. It's always the person giving the aid, not the person receiving it. Thank you very much, Prof. I hope participants and relevant stakeholders have listened to what you've said, and hopefully by God's grace, we start seeing positive response from different parts of the continent. That was a very great, direct presentation and thought-provoking lessons for all of us, both those of us in government and those of us running non-governmental organization. So we'll go straight to the next presenter. And without wasting time, I'll read his bio and hand over the platform to him. Our next presenter is Dr. Eman Edlin. He's a chairperson, South African Vaccine Injury Medical Legal Study Group, SAVIMS. and neurosurgeon medical legal practice heading Medical Legal Consultancy Trust. Dr. Elman is a prominent South African neurosurgeon and medical legal expert. He has made significant contributions to both medicine and law. He has authored numerous medical legal reports and served as an expert witness in countless court cases. In 2005, he has been involved with the South African Medical Legal Association, serving as its director and later as deputy chairperson. His role expanded to include membership in the HPCSA appeal tribunals, where he served as chairperson from 2014 to 2016. During COVID-19 pandemics, Dr. Elling publicly advocated for his scientific method, ethical medical practices, and human rights. In 2021, he addressed President Cyril Ramaphosa in an open letter entitled COVID-19 Pandemics, Health and Economic Crisis, urging transparent reporting of COVID-19 vaccine outcomes. Dr. Edling remains dedicated to advancing medical science, promoting ethical standards, and fostering mutual respect and understanding amongst people. He is joining us on this platform with his colleague, Dr. Masha Maharaj. So I welcome Dr. Ellen and Dr. Masha Maharaj. Please, you have the platform.
Thank you very much, Dr. Ayorotan. My name is Herman Edling, and thank you for the introduction. I'm the chairperson of SAVMS, and it gives me great pleasure to be here with my colleague, Dr. Masha Maharaj. You will be aware that recently SAVMS put out internationally a press release raising certain concerns in relation to monkeypox, particularly in relation to vaccination for monkeypox. Dr. Masha Maharaj was the primary author of the study group that worked on that document. The slides that she will present, she is also the primary author of those slides, and I have had some input. So the majority of our presentation will be given by Dr. Masha, and at the end, I wish to conclude with some remarks about ethics and science. With that, over to you, Masha.
Thank you so much, Herman, and also thank you to the organizers for inviting us to be on the platform. Are you able to see my presentation?
Yes, we see it well.
Yes, we can see it.
Thank you so much. Just to begin, there's no conflict of interest. To summarize what we know about Mpox, the incubation period is 3 to 17 days, predominantly a self-limiting disease, which may last from 2 to 4 weeks. It has a reportedly low mortality rate, but there have been no published data released with formal autopsy results linking the pathogenesis of death directly to Mpox. The diseases, the deaths for which we've had data available reported that 94% were immunocompromised with advanced HIV. The highest burden and longest persistence of replication of the competent virus is found in skin lesions. No cases of transmission occurred after skin lesions have healed. We have no information or no well-documented information on post-exposure immunity, and we are aware that there are viral strains emerging. So we're going to approach this from the ethics and the scientific basis for vaccination program. Ethics is an inherent and inseparable part of clinical medicine. There's 4 pillars of ethical principles, the beneficence, which basically says that it calls not for just avoiding harm, but also to benefit patients and promote their welfare. Non-maleficence, the physician must weigh the benefits against the burden of all interventions and treatments to issue those that are inappropriately burdensome and to choose the best course of action for the patient. Autonomy, all persons have intrinsic and unconditional worth. And this we determine from the informed consent, truth-telling, and confidentiality, and then justice. And the important one is distributional justice. Just to mention that all four must be taken into account, and we have the obligation to every patient to fulfill all four. In autonomy, the informed consent, the most important thing is that the patient must be able to understand. There must be a full disclosure. They must be able to comprehend the disclosure. They must act voluntarily to consent to the proposed action. Truth-telling is between the physician and the patient relationship in providing full information with tact and sensitivity to patients, which should be standard. In the scientific considerations for Mpox, we look at the clinical assessment, the differential diagnosis, the testing methodology, community-based healthcare interventions, basic medical interventions, and then we'll look at the vaccinations. So for us, we're going to focus on the vaccinations, the level of evidence, conflict of interest, and informed consent. So if we look at the level of evidence, and for those that are relevant, I actually put down the references for the slides. The level of evidence varies from level 1 to level 7, and the highest being level 1 of evidence. So level 7 is actually the expert opinions and the narratives and literature reviews that we tend to see quite often, and which is the lowest level of evidence. If we go to the clinical search engines, and I use the two most common, which is clinicaltrials.gov, currently using these criteria, there's actually 20 studies. Those that have been complete, those that are ongoing, and those that have been discontinued. And out of those studies, none of the reports have been, or the results have been posted. If we look at the PubMed Central, using monkeypox vaccine and Mpox vaccine and applying the filters for a high level of evidence, we do find about 110 studies. So we took the one which is the most comprehensive and looked like the most convincing with the most number of inclusions. And that was entitled Global Perspectives on Smallpox Vaccine Against Monkeypox, Comprehensive Meta-Analysis Systemic Review of Effectiveness, Protection, Safety, and Cross-Immunogenicity. So they actually did a very comprehensive search. They went through all the databases that were available, and they found 7,024 studies. But out of the 7,024, 6,987 had to be excluded because they were not consistent or could not be supported. 37 were then selected. And from there, they drove the evidence of 11 studies for effectiveness, 7 for protection, 10 for safety, and 12 for cross-immunogenicity. So they claimed at the end of the study, which appears to be quite large and global, that the findings show that smallpox vaccine is safe and effective against monkeypox worldwide. And this is verbatim. Individuals infected with HIV and those not vaccinated against smallpox are at a higher risk of death. So we thought that was quite important for us to investigate in the literature. But they said this, but there were irregularities and several limitations in the studies, which I want to bring to your attention for those who are listening, which is what we look at when we look at literature. Their study designs were heterogeneous, unable to assess immunogenicity of the vaccine. They were claiming cross-immunogenicity, which is cross-protection, limited population at-risk groups. So most of the groups that they were studying, from the studies that they took, were actually healthy groups with minimal risk of exposure. The data could not be combined for meta-analysis. There was paucity of vaccine research data available. And this is actually from their own limitations that were documented. Also contradicting content reporting was noticed. So firstly, their relative risk for contracting infection post-vaccine ranged between 31 and 68%. So you could lie anywhere between that percentage post-vaccination for getting the infection. So it means it was not going to be effective for you if you lied in the lower part of that spectrum. Also, for contracting severe monkeypox post-vaccine was ranging between 42 and 87%. And then contracting infection post-third versus first generation vaccine was 22 to 56%, which is a quite significant range, and obviously disputes the safety and effectiveness. Then also within their own study, they mentioned that HIV-positive Mpox participants who received a single dose of Jynneos vaccine were more likely to be hospitalized than HIV-positive participants with Mpox who did not receive the vaccination. So those who did not receive the vaccination were much safer. And that obviously discredited the individuals infected have a higher risk of death. So from that, there is no high-level evidence of Mpox vaccine safety or effectiveness. So to date, there's actually no vaccine candidate that is available to control the spread of monkeypox. There's similarities with orthopox and antibody cross-reactivity, which is what we are talking about, the cross-protection. And based on the vaccinia, so we have the first generation, the second generation, and the third generation. And the third generation is the Jynneos and Mpox, and the second generation is the ICAM. So for the sake of our time, I'm actually just going to go through the second and third generation. The first generation has been completely discontinued because of very serious adverse effects from the vaccine. So if you look at the ICAM, and I've taken this directly from the website that gives us the package insert, we see that firstly, it has not been studied in pregnant women. The live vaccinia virus vaccines can cause fetal vaccinia and fetal death, which is quite significant. So those who are pregnant should not be even taking this vaccine. Then if you look at the warning, which is on the front or on the top of the package insert, there's various lists of warnings that we get for serious adverse effects, from myocarditis, pericarditis, Stevens-Johnson syndrome, blindness, fetal death, permanent sequelae, also death. But one of the most interesting ones, if you go further down the package insert, and again, I'm referring to the package insert because this is on the website. The interesting adverse reaction is death of an unvaccinated individual having contact with a vaccinated individual. So even those who have not been vaccinated are at risk of adverse effects if they come into contact with those that are vaccinated. So the next one, which is the third line vaccinia vaccine, is the Jynneos. And this vaccine is indicated according to the website for smallpox or monkeypox. It has been studied in patients 18 years and older. And we have a list of the information leaflet of the adverse side effects. But of interest, and I'm just going to highlight two, because if you go through the rest, you can also see diseases such as Crohn's disease, sarcoidosis, extraocular muscle paresis and throat tightness, etc. But out of interest was syncope, which is fainting following the vaccination. So vaccinations are subcutaneous injections, and we find that this is a very serious side effect, that a subcutaneous injection can cause and result in fainting subsequent to the injection. Also, on the safety information, it does state it may not protect all recipients. One of the multivalent mRNA vaccines that's currently being studied is BNT166, and you can see the clinicaltrial.gov study link on the top. These actually we have no data for. We have no, there's no evidence that it's safe or effective. These currently are purely experimental. And the risk of experimental vaccines to the population outweighs any conceivable benefits until proven otherwise. So the question is, can we ensure full disclosure that is representative of good clinical practice to fulfill criteria of informed consent and truth-telling? So from our series, from our research and from what we've looked at the literature, there are actually no longitudinal studies that confirm that the safety or efficacy of current available Mpox vaccines in the recipient's lifetime. So when we say longitudinal studies, we mean the study actually follows a recipient from the time of receiving that vaccination until their time of death, and then proving the safety and efficacy of that vaccination. At best, with current literature, there can be a level 5 to level 7 evidence, even if we allow the misprints and the limitations to this. So there is a paucity of data on acute, subacute, and long-term adverse events. The immunogenicity of the vaccine is also, we are unable to locate the data for that, because at the moment, all we are talking about with these vaccines are cross-immunogenicity. Then also the quality of life post-vaccination. So we are unable to get information. How was the patient post-vaccination? What was the quality of their life? What type of morbidity, mortality occurred, and could that be attributed to vaccine injury in Mpox? Also, the information on accountability, reimbursement, and treatment interventions for vaccine-related injuries. Who is responsible? Will it be the regulators? Will it be the physician administering? Will it be the healthcare professional administering? Will it be the third-party NGOs or vaccine pharmaceutical agencies? Or will it be the investors? Who will be accountable to these patients who are maybe breadwinners in their families, and they have received the vaccine and then develop a side effect or adverse event that is not allowing them to work any further? So there's also a conflict of interest in data reporting, prescribing parties and their affiliates. And we showed that with the article that we have subsequently broken down for you. So from our perspective, there's insufficient evidence to provide a comprehensive, full disclosure of Mpox vaccination for the Mpox vaccination program. I'm going to summarize, and then I'm going to hand back to Dr. Edeling. In summary, we cannot find any ethical grounds for the insertion of a vaccine program in the Mpox protocol in Africa. We have not found any evidence of a benefit of using vaccines that outweighs the risk. Professional integrity is compromised by prescribing ineffective drugs or expensive drugs when effective, inexpensive drugs are available. Performing invasive treatments or experimental research modalities without fully informed consent compromises in professional integrity. And any situation where personal monetary gain is placed over a patient's welfare compromises professional integrity. In Africa, our African experts have great experience in successful disease containment with rapid institution of disease surveillance to detect, diagnose, isolate, and treat cases, but also with contact tracing among engaged, involved, and awareness of communities. So this is the summary from my side. I'd like to say thank you again to GET and hand over to Dr. Edeling. Thank you so much, sir.
Thank you very much, Marsha. That was excellent. I'm going to make a few brief comments. So Marsha has very well presented the findings and the approach of SAVMS. The first thing I want to say is to particularly thank all the previous speakers for the scientific and factual information they provided about this condition, about the outbreaks and about measures. And then especially to thank Professor Tomori for such a hard-hitting and clearly truthful and important contribution. If anybody is interested in my advice for preventing and treating monkeypox in Africa, it would be listen to Professor Tomori, do what he says, and if you want to spend money on this problem, give the money to Professor Tomori. He will know what to do with it. So thank you very much, Professor, for that. I'm going to limit my further comments to the concept of informed consent in relation to vaccination. I'm not going to say anything further about about the epidemiology or the treatment of monkeypox, but it is on informed consent. Now, in order to provide proper informed consent, the first necessity for the healthcare practitioner is to approach the knowledge with proper science. And to approach knowledge with science requires all the fundamental elements of a scientific approach. One cannot give informed consent on the basis of narratives, or on the basis of opinions, or on the basis of wishful thinking. Informed consent has to be based on truth. And the closest we get to the truth about anything is by following the scientific method. The next foundational element of informed consent is that the science has to be presented ethically. And Marsha has spoken about that. Now, I want to refer just briefly to the publication that Marsha dealt with, which is there. Can I just ask you, do you see global perspective on smallpox on the share screen?
Yes, we can.
Yeah, we can.
So this is the article to which Marsha referred. Now, if one looks at the title of this article, it's very impressive because it's global perspectives, smallpox vaccine against monkeypox. That is exactly what we want to know. It's called a comprehensive meta-analysis and systematic review. So those are big words that mean that these people have gone to a lot of work to do a very detailed scientific study. And they have studied the important things: effectiveness, protection, safety, and cross-immunogenicity. So by reading that title, I would think this will tell me everything. This will be the state of the art of current important knowledge on this topic. Now, in the abstract, I've underlined these words, which is the bottom line conclusion of the authors. Our findings offer compelling evidence supporting the clinical application of the smallpox vaccine for preventing monkeypox, and advocate that high-risk groups should be prioritized for receiving one dose of the smallpox vaccine if the vaccine stockpile is low. So that is a very strong and apparently scientific promotion or recommendation to use these repurposed smallpox vaccines for monkeypox or Mpox. But did the study really find that? And are the actual findings of the study, can they actually be interpreted to bring us to that conclusion? So I wanted to show a few things. We haven't got a lot of time to analyze this in depth. So I have analyzed this article or this publication superficially, but I'll show you what I found. One of the statements, Marsha also referred to this, third-generation vaccines showed greater efficacy than first-generation vaccines, and she gave you the percentages. Now, on that point, I will show you the table 1 in this publication, which details what studies were used. So that table shows all the different studies, the 37 studies which they analyzed. These ones down here were all analyzed for studies that gave information on cross-reactivity. Sorry, let me just get back to the right place. Cross-immunogenicity. Those studies were on safety. And then those studies are on protection. Now remember, the statement that I referred to in the abstract is about efficacy. So, and I'm going to focus in this study mainly on the so-called effectiveness findings, because I think that is a concept which is largely misunderstood, not only by lay people, but also by doctors. Now, this first group, which I've outlined in blue, you'll see all of these studies were effectiveness studies. Now, the concept that they referred to, where the third-generation vaccines gave greater protection from severe disease than the first or second generation, does not come from the effectiveness studies. It comes from the protection studies. And in the protection studies, so we don't find anything relating to or first-generation vaccines in the effectiveness studies. You will see that all of these vaccines in this box were third-generation vaccines. So when the studies that they analyzed for effectiveness were all third-generation vaccines. So how does it occur that the authors can make a comment about the comparison of third-generation versus first-generation when they haven't included any first-generation vaccines in their effectiveness analysis? So I don't know how important that is. It just is something which doesn't make sense if you look at the content of the study. I don't know how they got to that figure. And I think that's an important question that any authority who is interested in these vaccines should ask the people selling it, the people making it, or the people promoting it. Now, so I'm now going to focus on the effectiveness portion of what they describe in this article. Now, I will show you in a moment, but in communicating the findings of a scientific study, it's very important to differentiate between effectiveness findings and efficacy findings. We will get to that in a minute. Now, efficacy, the calculation of efficacy in a study, is the same thing as a relative risk reduction. So relative risk reduction calculations in studies equate to efficacy, not to effectiveness. Now, all the figures quoted here under the effectiveness heading, you see there, relative risk 0.46, relative risk 0.51, relative risk 0.40. All of the figures quoted in this study relate to relative risk reduction, which means the same thing as efficacy. None of them have made findings that I can understand that relate to effectiveness. Now, that aside, if we look at the analysis by region, bearing in mind that, as you'll see in the table, they did studies in many different countries. In North America, they found the relative risk of infection was 49%, lower than with vaccination and without. So the protection was 49%. And in Europe, 60%. So that seems the vaccines work better in Europe than in America. But now they say in one study in Africa, smallpox vaccine reduced the infection risk by 69%. So that is a very nice claim if you live in Africa, because it means that this compelling study found that the vaccines are more effective in Africa than in Europe or in America. So then let's go and look at the tables to see where they found that. They say one study in Africa found 69% protection, relative risk reduction. All right, so let's go to this again. And we will obviously find the study they're referring to in the studies that were done on effectiveness, because that's what they're reporting. So there's all the effectiveness studies. Here are the countries in which the effectiveness studies were done. You will see not one of them is in Africa. So where did they get the 69% protection if they didn't have any study from Africa? Because they say there, one study from Africa. So let's see if there's an African study in the rest of this. Oh, yes, there is. There, Kathan et al., Central African countries, Mpox. Oh, that study only had 24 participants, so it was a very tiny proportion of the 37,000 or so that they're reporting in the study. So the only African study included in this meta-analysis is a single study with 24 participants. There's no other African study listed here. And by the way, that study did not deal with effectiveness or efficacy. It dealt with protection. And if you read the meanings in this study, protection means protecting you from severe illness as opposed to mild illness. Whereas what they quoted in the text of the study was that there was 69% protection from contracting monkeypox. Now, you can't make that if you haven't got that study in your table, in the 37 studies that you analyzed. So let's just go and look at where does that come from? So there it gives it 69% in the African study. They referred to reference number 24. Right, so let's go to the references at the end of the article. There's 24. This is Wolf, Sagi, Zucker, Hammersman. Real-world effectiveness of a single dose of Mpox vaccine in males. Okay, so that is a study about effectiveness. But why is that study not included in the table? In other words, this study they put in their references, but it wasn't one of the 37 studies that met their inclusion criteria for the meta-analysis and systematic review. So these authors thought or found there was something inadequate or wrong about this study that made them not able to include it. But however, in the text, they make the statement that the study found 69%. So it is problems like that that makes a scientist, an analyst, especially one who is accustomed to facing cross-examination, very concerned. How do they find that? And if one finds something like that, which seems to be wrong, what does that say for the rest of the findings in this study? Now, when they analyzed these, not by region, but by sample size, they found 4 studies with a small a sample size of 500 to 1,000, showed a 19% reduction in incidence of Mpox. So 19% protection is really very poor. But then other studies, 5 studies with a sample size of more than 1,000, showed 67%. So which one is true? Are we just going to accept that because the sample sizes of these were bigger, that your patient's risk reduction will be 67%? Or might it be that your patient's risk reduction is only 19%? And interestingly, in that figure of 19%, the confidence interval, 95% confidence interval, was a relative risk of 0.4 up to 1.67. What that 1.67 means is that at least one, or that the vaccinated people in some of these studies had a higher risk of monkeypox than the unvaccinated. So the vaccinated group had 1.67 times the risk of the unvaccinated group, whereas others had only a 0.4 risk, or a 40% of the risk. Now, what can it be that makes that spread so wide? How can a substance protect some people by 19% and others by 67%? And is the answer to that question that the participants in the studies were not equivalent for disease, comorbidities, infection risk, other issues? And with such a wide spread of apparent risk reduction, how trustworthy is it for your patient who you are going to advise the vaccine? What must your patient believe? They're going to get a 19%, or they're going to have a higher risk of infection, like some of these did, or they're going to have a 67% reduction in risk. So that means more or less what Marsha said. The evidence is very sketchy, and it is not as simple or straightforward as to make this claim that is made in the abstract, nor the claim that is made in the conclusion of the article. Now, I'm not going to go into any of the further details here, but it's many details that I've considered, which shows inconsistency, variability, difficult to explain numbers, which means that the reliability of all of this has to be called into question. So what is the ethical duty of the health authority making a decision whether to import a vaccine into the country. Well, that health authority has to give informed consent. And in order to give informed consent, the person or the persons making the decision have to do not just a superficial analysis that I've done on the study, but have to do an in-depth analysis on the study or studies that are put forward by the organization providing the vaccines or by the manufacturers of the vaccines. Now, why do I say that is so important? I'd like to show you some evidence. I spoke about the difference between the meaning of efficacy and effectiveness, and that is important. Now, this document comes from Gavi, who everybody knows very well. And Gavi explains what efficacy is, and they explain what effectiveness is. And essentially, efficacy is, in a study, the proportion of the study group who got a condition or an outcome compared to the number of people in the control group who got the outcome. Whereas effectiveness means how effective is this at reducing the risk of this condition when it's rolled out in the general population. And as Gavi says here very clearly, once the efficacy of a vaccine has been determined, measuring its effectiveness is critical. Now, in the study that I've shown you, as much as they talk about effectiveness, they have not measured effectiveness. All of those numbers, those percentages, those relative risks are all efficacy numbers that are found in the studies. They say effectiveness of a vaccine is measured by what epidemiologists call observational studies because participants are not randomly assigned to a treatment versus a placebo group. Okay, so is it just me that thinks it's important? I want to show you what the FDA says about it. So this is a document of the FDA published in 2011. So it's before the COVID pandemic. It's about communicating risks and benefits, an evidence-based user's guide. All right. So I'm going to go to absolute risk reduction. I'm just going to, it's a very long document, 242 pages. All right, so here the FDA explains three very important concepts in reporting what studies find: the absolute risk, the relative risk, and the number needed to treat. And they say, when explaining risk associated with treatment, three approaches exist to describe how the treatment changes risk. For example, when explaining the benefits of taking chemo prevention to prevent breast cancer, risk reduction could be described as, first of all, a 50% reduction, which is a relative risk reduction. A reduction from a 6% risk to 3%. So if the treated group has a 3% incidence and the untreated group has a 6% incidence, it is correct to say a relative risk reduction of 50%. That means an efficacy of 50%. But the absolute risk reduction is 3%. It's not 50%. And it's important in communicating to the decision makers and also to the patient who must decide whether to accept a vaccine, not only what the efficacy or relative risk reduction is, but also what the absolute risk reduction is. And I will just go to the next important point that the FDA states. And this is a very good recommendation of the FDA. Provide absolute risks, not just relative risks. Patients are unduly influenced when risk information is presented using a relative risk approach. This can result in suboptimal decisions. Thus, an absolute risk format should be used. So I'd like to give you an example of why this is important. And this example is also going to include the concept of the number needed to treat. If you were to do a study of 2,000 participants, and you give the vaccine to 1,000, and you give saline to the other 1,000, And then you find that in the placebo saline group, 5 people got monkeypox. And in the vaccine group, 2 people got monkeypox. So of 1,000 in the one group, only 5 got it. And of the 1,000 in the other group, it was less, only 2 got it. Then you would correctly report a relative risk of 0.4. That means a relative risk reduction of 60%. And you can then correctly scientifically tell your patient the study found an efficacy of 60%. Because by saving 3 people from getting monkeypox out of 5, it gave 60% protection. But it's also important to say that of the 1,000 who were not vaccinated, only 5 got it. And only of the 1,000 who were vaccinated, only 2 got it. So the absolute risk reduction was 3%. Because if your risk is 5% without a vaccine and it's 2% with a vaccine, your risk reduction with the vaccine is 3%. It's not 60%. And the number needed to treat means in order to protect 3 people from getting monkeypox, you've got to inject 1,000. Now, that is important when the patient and the health authority and the doctor must consider the risk-benefit ratio. Because you must, before you can ethically and with informed consent advise a treatment like a vaccine, you have to have scientific evidence that the benefit outweighs the risk. And it has to be a significant benefit outweighing the risk. Now, if you know that the benefit is you've got to inject 1,000 to protect 3, then you have to look that if the risk of adverse effects is 0.3, that means 3 out of 1,000, then you will protect 3 from getting the condition, and you will give 3 people will have significant side effects. So you have to consider number needed to treat and absolute risk reduction and relative risk reduction or efficacy before you can determine whether it's worth it because of the risk-benefit ratio. Now, I would like to just give you very briefly an overview of what happened with the COVID mRNA vaccines, with the principles we've mentioned. This is the publication in the New England Journal of Medicine, December 31, 2020. This was on the Pfizer BNT162b2 mRNA COVID-19 vaccine. And the results, the conclusion of this study was that that vaccine gave 95% protection against COVID-19. That was the finding. That finding was spread, narrated all around the world. And I was presented with this over television and expert opinion over and over that this was a very good vaccine because it gives 95% protection. It comes from this study. As far as safety goes, they made a strange statement. They said safety was similar to that of other vaccines. Now, that doesn't really fill me with confidence because what is the safety of other vaccines? And how safe was this vaccine? Anyway, the authors of this study, 84% of them had a conflict of interest. Only 16% of the authors had no ties to Pfizer or BioNTech, but 84% were either employed by, had shares in, or had ties to Pfizer and or BioNTech. One wonders why the New England Journal of Medicine, which is a highly regarded peer-reviewed publication, would publish an article on a study with such an obvious and massive conflict of interest. Now, the data of this study was analyzed by independent investigators. And I want to refer first of all to this publication by J. Bart Klassen. This is a research article published in where is that? Sorry, Trends in Internal Medicine. And this was published in July 21, so only 6-7 months after the New England Journal of Medicine Pfizer article. And what did Klassen find? That the COVID-19 vaccines are proven to cause more harm than good. That finding was based on the pivotal clinical trial data, which is the one I've just referred to, which he analyzed using the proper scientific endpoint, which is all-cause severe morbidity. Now, Klassen didn't go to any other data. He went to the data of that trial, and he analyzed the number of participants in the vaccine group who had severe morbidity of any cause, as opposed to the number of placebo participants who had severe morbidity of any cause. And he found Pfizer claims their vaccine prevented 8 cases of severe COVID-19 out of 21,720 immunized. Okay? He says the Pfizer data was grossly incomplete, but data provided showed that vaccination group suffered 90 more severe events than the control group. So Pfizer's claim was that we protected 8 people from severe COVID, but what they failed to mention, 90 people got severe adverse events. So that is not a beneficial vaccine. If you protect 8 from severe COVID, but you give other severe conditions to 90. But Klassen was not the only analyst. An article was subsequently published in the journal Vaccine. And these are very well-known authors, Joseph Freeman, Peter Doshi. I'm not so familiar with the others, but I am familiar with those 2 names. They also analyzed the same study of the New England Journal of Medicine. And whereas Klassen had looked at the severe all-cause morbidity or all-cause severe morbidity, these authors looked at a different outcome, which was serious adverse events of special interest. And what they found was that they studied Pfizer and Moderna. They found that those vaccines were associated with an excess risk of serious adverse events of special interest of 10.1 and 15.1 per 10,000. So that means for Pfizer, it was 10.1 per 10,000 at a risk of severe adverse events of special interest. Sorry, serious adverse events of special interest. Now, to see, you've got to look further down in the study, in this article, to see what that really means. And that is that according to Pfizer's own effectiveness or efficacy, it was a far lower number than that. Here in the harm-benefit considerations. In the Pfizer trial, the excess risk of serious adverse events of special interest, which was 10.1 per 10,000, was higher than the risk reduction for COVID-19 hospitalization relative to the placebo group, which was 2.3. So Pfizer claimed in their trial, we kept 2.3 COVID patients out of hospital. But what they didn't mention per 10,000, we put 10.1 in hospital because of serious adverse events of special interest. And it's not just those investigators, because we also conducted an in-detail depth analysis of the data in that study. And I'm just going to present a very small portion of what we found. In that study, that is 31 December 2020 Pfizer study in the New England Journal of Medicine, which claimed 95% protection, that claim was based on an efficacy calculation, which is the same as the relative risk calculations that are referred to in this monkeypox or smallpox vaccine for monkeypox. It was based on these 2 numbers. In the vaccinated group, 8 people had COVID. In the placebo group, 162 people had COVID. Those numbers are really strange because there were almost 18,000 participants in each group. And this study was conducted in 2020 in the midst of a worldwide pandemic, which was a very serious pandemic. How likely is it really that out of 18,000 people who got placebo, only 162 had COVID? And out of 18,000 vaccinated, that only 8 had COVID. Now, the diagnosis of COVID cases in this study was any one of 13 symptoms which are listed in the protocol, plus a positive PCR test. So if you had symptoms but not a positive PCR test, they didn't count you as a case of COVID. So then we found in the data tables, we found people in a single week, that was in week 4 of the study, where they counted specifically people with COVID symptoms, that in that week, 58% of vaccinated participants were ill with COVID symptoms, whereas only 21% of placebo participants were ill with COVID symptoms. Now, the 21% of placebo would be 3,775 people. But why do they only find 162 with COVID? But what is really startling is that in the vaccinated group, it's 10,439 people were sick with COVID, with COVID symptoms. But of them, we must miraculously believe only 8 had COVID. And then when one digs further, one finds the answer to that question, because the answer is they didn't do PCR tests on all of these people with COVID symptoms. So if they only do tests on a selective group, what trust can you put, or what reliability scientifically can there be in the numbers that they kick out here, the 8 and the 162, who had a positive test and symptoms? Is it not more meaningful to look at how many were sick? And you'll see in the vaccinated group, far more were sick with COVID symptoms than the placebo group. And of those with severe COVID symptoms, which is defined as preventing daily activity, in other words, people who were confined to bed at home or confined to bed in hospital, 684. Are we to believe that of those 684 people who were confined to bed, who had the vaccine, only 8 of them had COVID? And if so, what did the other 676 have in a COVID pandemic that confined them to bed in that single week? So that is where I would wish to end the things I want to show you. And I want to close off by saying the following. And it's limited to informed consent and vaccination for Mpox. We in SAVIMS have found no evidence, and we do not believe there is any evidence of an adequate medical scientific certainty to support the use of mRNA or DNA or any genetic type vaccine for any infectious disease. We have not been able to find any study that shows a risk-benefit ratio where it was a good idea. So at this stage, and with the current development of technology, our very strong recommendation is forget about pursuing the development of mRNA vaccines for monkeypox or for any other condition, because whoever looks independently at data relating to the COVID-19 experimentation finds that the experiment has failed dismally. And there are very good reasons for it, which we can go into. Anybody who understands immunology and vaccinology and virology have been able to predict that it would not be a good idea and it would not work. When it comes to antigen-based vaccines, and I'm pleased that that is the only one that is being considered, as far as I can see, is that those who wish to consider or introduce or recommend antigen-based vaccines should not base their decisions or their information to patients simply on the claims that are found in the abstracts or conclusions of studies or in the claims of manufacturers, but they should base their understanding on a proper in-depth analysis of the data. With that, I thank you.
Thank you very much, Dr. Edling and Dr. Maharaj, for that very detailed presentation on vaccine ethics, especially when it comes to Mpox vaccination. you agree with me that ethical issues around vaccine is a very topical issue, especially when it comes to emerging infectious diseases like Mpox. And thank you for sharing the research your organization Savvy have done in that direction. And I strongly advise our participants to go and check EVIMS out online and read through their works and the research they've done on ethical issues in the area of monkeypox, of Mpox. And I'm going to do that myself. I'm going to go into details because we've shared so much information that we have to start breaking down to learn more about ethical issues on Mpox. And we have to round up the webinar now. We spent so much time. We spent almost 2.5 hours on the webinar today. And I want to start by saying a very big thank you to our panelists that have spoken in the last 2.5 hours. We've learned so much from your wealth of knowledge, Dr. Edling, Dr. Brian, Professor Tomori, Professor Burch, and Dr. Maharaj. Thank you for those very educative presentation, and we've learned so much. Personally, I've learned so much from your presentations, and I'm going to go back and listen to them again to have a deeper understanding of your presentations. And I also want to say a very big thank you to our participants. We've had over 200 participants from almost 40 different countries today. And most of them have stayed with us, stayed glued to our platform in the last 2.5 hours. We thank you very much. Like I always say, you are the reason why we do it. We do this every month. And like I said at the beginning, number one, we're going to share a certificate of participation with you after this webinar. Within the next 2 days, you'll get your certificate. And we're also going to paste we're going to post the webinar, the video on our YouTube channel. Our YouTube channel is Get Africa, WGET Africa. We have over 150 videos there on different subject matters in relevant areas. So go to our YouTube channel and learn more about our webinars and other videos posted by Get. And finally, I'll give a summary of some of our activities. In November, Get will be organizing the 10th edition of our annual conference on One Health and Biosecurity. A conference, we've organized it in different countries in Africa in the last 10 years. And we'll be celebrating our 10th anniversary in Lagos, Nigeria, from November 6 to 8, 2024. We invite everybody to be part of that meeting. Our conference is going to be one of the biggest platforms to discuss emerging issues in the area of biosecurity and One Health on the continent. Also, we'll run the Get Journal series, Get Journal of One Health and Biosecurity, where we'll publish genuine manuscripts in the area of biosecurity and One Health, especially for Africa. You agree with me that the contribution of Africa to global research is very low, and that's why Get created a platform to give Africans the opportunity to publish their genuine research work on that platform, and publication is absolutely free for Africans. We're going to be publishing an edition of the journal before the end of the year, and we also have our Get Policy Brief series and our Get Technical Paper series. So these are platforms you can use to share your original research materials with experts on the continent and increase research outputs by Africans on the continent of Africa. But with that, we've come to the end of today's presentation, of today's webinar. I thank everybody, our presenters and our participants, for staying with us for over 2 hours to discuss these very important issues. 4 words I learned, or 4 things that came to my mind during the webinar today. First one is collaboration. We can't work in isolation. You need to work with each other to solve emerging problems in the world. Accountability. Africa has to be accountable to itself and accountable to Africans. Equity. Equity is not given, equity is negotiated, and you have to negotiate equity based on your strength, not from your weakness. And the fourth one is ethics. Ethics is very important when it comes to research, especially live research and dealing with human beings. So these are the 4 words that came to mind as we went through the webinar today. I thank you again, our presenters and our participants, for joining us. We'll organize another webinar this time next month by God's grace, and we look forward to meeting you again on very important topical issue that we'll be sharing very soon on all our platforms. Thank you from us, all the staffs in GET, and have a blessed rest of the day. Thank you very much. Bye-bye.